I'd like to invite Dr. Lalit Verma, our president, to give his talk. He'll be talking, is will OCTA replace fluorescein angiography? And the same question I'll ask Puneet also, whether he is using fluorescein angiography in cases of choroidal neovascular membrane or macular disease.
For macular degeneration, I think if you have OCT angiography, there is no much role of doing fluorescein angiography. You can delineate choroidal neovascular membranes much more effectively than fluorescein angiography.
Especially in neovascular AMD, was only for identifying classic CNVMs for doing PDT. Now that is totally out of the window, and once anti-VEGF therapy has come in, there's no real need to distinguish the types. The only real area is to distinguish between neovascular AMD and perhaps an polypoidal choroidal vasculopathy, where you really need FFA with ICG. So that is one. Also, in cases where you suspect that there may be a RAP lesion, and so you would like to see, that early angiogram, the emanation from the retinal circulation. So these are the indications. But as Dr. Puneet said, by and large, for neovascular AMD, you really don't need fluorescein angiography as much as
Dr.
Rajesh.
And Ritesh and Rajesh, whether you need angiography in case of
Sir, FFA for AMD is, I've stopped using. I don't use FFA. I think OCTA is more than sufficient and better than FA, and it's quick and it's more reliable.
Yeah, I just had a question. If the AMD patients, advanced AMD, who have fovea involving diseases, the fixation is a problem in acquiring the scans many a times. So many segmentation artifacts and motion artifacts do happen, especially if the patient also diabetic patients who have significant.
I'm happy some man is there to defend this also.
So any tips to improve the image quality?
if there is a there's a poor fixation in one of the eye, you can ask you can give an external fixation to the other eye and then take the scans.
Then
The only thing is this disease do progress bilateral symmetrically. So in the other eye also many a times.
Yeah, some cases it's difficult. I totally agree with you. Sir, please.
thank you, Vrinder. I think deliberately he has given this topic to me because all these are young people. They've recently acquired OCTA machines and they have a lot of experience. And I, being all gray hairs, am more, using FA machine and gradually learning OCTA. Thanks, Vrinder, for designing this session so well. You see, today is an era of multimodal imaging. We keep talking of all these modalities which are there. And OCTA is now not a new baby, but recent addition to all this. What I am going to convince you is that even in this era of, this 10 multimodal modalities listed here, FA, I think, is still not dead. A lot of people keep saying that they use only OCTA, but I am not one of them that I will use only OCTA for this thing. The only conditions where I have used only OCTA is maybe myopic CNVMs or otherwise to my thinking it does not replace fluorescein angiography also. FA is now, we have wide field, ultra wide field. Even OCTA also is now has, more machines are available for wide field. But still, there are limitations, whereas wide field angiography is now more easily available. Long experience with the FFA, and in a very short span, you get wealth of information about so many diseases. Apart from being cheaper and less artifacts, what was being talked about now only by one of the members here, less motion dependent. Plus, it's a dynamic study. You study the flow. Although OCTA also is dependent on, like Puneet was saying, some flow. If there's no flow, you may not be able to differentiate much. Neovascularization, a lot of times I've been misled actually. I've been misled primarily because there are so many patients who have what we call quiescent CNVM and or we early kind of CNVM, which pose a dilemma. Because if you keep seeing this photograph on the outer level, you see those neovascularization, you're not convinced whether to treat or not. And if you are treating only on the basis of OCTA, you may over-treat such patients. Disadvantages of FA are there that people will shout, of OCTA proponents will shout that it's invasive, and even death has been reported. One death has been reported, but believe me, they're so rare, so rare. So here I have tried to make a table here, and red one indicates the plus points of the respective machine. So wider angle FFA is very easily available nowadays. OCTA, the advantage is non-invasive, can be repeated whenever you want, but it requires a lot of learning. You have to sit there on the machine for a very, very long time to keep understanding. And resolution definitely is much higher. And big advantage is this NFAS imaging, that all 4 levels can be segmented: superficial, deep, outer retina, and even choroidal. But FFA is known for its dynamicity, plus less of these artifacts. Equipment cost is cheaper, and then decades and decades of experience is there. I will try to list a couple of conditions where FFA has helped me more than OCTA, so that just to impress that FFA still has a role. Especially wider field angiography if you do, and peripheral lesions, I'm not very comfortable doing OCTA in such conditions. You see, whether it is vasculitis, Eales disease, or peripheral NVE, people may say that you can pick up on indirect angioscopy also, but you see these pictures here tell the story itself. Leakage is another thing which never I'm confident, although flow indices have been described in OCTA, but I'm very comfortable picking up leakage, which indicate the activity of the disease. Other thing is about the dynamic property of leakage, which is unique to both FFA and ICG. CNVM, as I said, although Puneet said that you can have idea about whether it is regressed, but I will be very comfortable in case it is leaking there on FA or not, to confirm, like in this patient. Like I said, ultra wide field FFA is a definite reality. Motion artifacts is one thing which is, all these artifacts, in fact, which are not there in FA. Media haze is another issue. Like if you have a media haze, then OCTA becomes impossible, whereas you can have some information here. Limited fixation, as was being pointed out, patients may have bilateral ARMD, even external fixation may not work. This is not much of a drawback in angiography. Then other thing is decision making. Decision making is very difficult only on OCTA. In a lot of diseases, especially diseases like if I have to laser a non-center involving DME or a CSR, I would not depend on only OCTA information. And even in things like Coats disease or retinal artery angiomatosis or RAM. So here I would have a frame of FA before I start lasering these patients. Microneedles, people say you can still have an idea on OCTA, but very readily and easily visualization on FA also. Same is true for this. If you have to differentiate between, a lot of people try to confuse between CSR and VKH lesion. I'm very comfortable doing an angiography in these patients and for documentation also. So what I have done is to describe a couple of regions where I'm very comfortable with FA, although I am wary of this fact that OCTA is gradually replacing FFA and ultimately may occupy that position. But as of now, I think FA still is there and is not dead for a lot of these conditions. Thank you very much.
Thank you, sir. A very important point what sir has mentioned is that in OCTA you can see the vessels, but you cannot see the leakage. So only leakage early and late phase you can only determine on fluorescein angiography pictures. Many times we have an laser proliferative diabetic retinopathy, and you do an OCTA, you will see a network of vessel and you will say ki I have to do some laser. But the moment you do a fluorescein angiography, there is no leakage, and actually this patient does not require an addition of laser. CSR patients, uveitis patients, still FA is the gold standard, and OCTA, we cannot replace OCTA with fluorescein angiography. Yes, macular disorders, we are gradually weaning off from fluorescein angiography, but peripheral vascular lesions, OCTA still, fluorescein angiography still is the investigation of the choice. Any comments from Ritesh or Ajay and Doctor?
I agree on a lot of points,
You
Dr.
are
Mehta.
you are free to differ also. It's not necessarily concurrence, but this is what I could pick up where it has helped me.
So for me, OCTA, if I pick up a neovascularization on OCTA at the initial stage, I won't go for an FFA. I'm not talking about under treatment eye. But if I don't pick up on FFA, on OCTA, and my clinical suspicion is high, I rely on FFA to confirm it or not. So finding on OCTA is very strongly positive, but not finding on OCTA does not rule out a disease completely. So
Agreed.
one has to keep that
Yeah.
in mind.
Yes, I agree, because just harking back to the point which I think Dr. Aminda and Ritesh made is sometimes networks may not show. It's all flow dependent. It's virtual. The Octron network is actually virtual. So if the flow is very slow, you might just miss a network. Also, if the slabbing is not perfect because the RP is highly corrugated, then you may miss it also. So
Yeah.
these are issues which that is where FFA will score.
Also, the fact that I'm not a retina specialist, but we've realized that if you do a fractal analysis instead of the inbuilt SSADAs and the other algorithms you mentioned, you actually tend to get better quantitative analysis. And like you said, since there's not real flow cytometry, you're actually sort of looking at missing points. And if you have low flow and slow flow, you will actually miss those points.
And if you have vitreous hemorrhage and if you want to
Yeah.
define a lesion
Yeah.
in vitreous hemorrhage, you won't get octa images because of the shadowing and poor equation. You have to rely on fluorescein angiography. Thank you, sir.
Absolutely.
Thank you
Thank you.
for your
Thank you.
kind wisdom, words of wisdom, and sparing time for